Hello, my name is Heather Issa, and I'm the clinical coordinator for the radiography program at Brown University Health School of Medical Imaging. I am also a registered radiologic technologist. I also am a per diem technologist at a hospital here in Rhode Island, and I've been practicing for about 13 years now. So today I hope I can further educate you about the profession of a radiologic technologist or X-ray tech, so you can make a more informed decision about going into the radiography field. My goal is to help clarify some of the common misconceptions about the field and then speak to some of the day-to-day responsibilities that you would have as an X-ray tech. I also want to highlight the many opportunities for both professional and career growth, and I hope I can convince you of the rewarding aspects of this career. I've been a practicing tech for about 13 years now. There are a lot of different places that you can go once getting your board certification, and then we'll talk about these towards the end of this presentation here. But let's get into what being a X-ray tech truly entails first. So I want to start with some of the common misconceptions about a career as a radiologic technologist. Firstly, people tend to think that all we do is stand behind a console and push a button for our jobs. And yes, while we do, have a job similar to a photographer, we're taking images of bones and body tissue, we obviously need to have a thorough knowledge of human anatomy, as well as the physics of X-ray interactions within the body. Imaging requires critical thinking, problem solving, and technical expertise. So while yes, it looks to the outside world that we just push a button and an image pops up, you must be able to figure out how to position a patient, set radiation techniques based on patient conditions, injuries, pathologies. And then we also have to maintain a standard of image quality because our radiologists use our images to dictate and diagnose patients. So again, it seems very simple. We just push a button, but there's a lot of background knowledge that we would teach you here in school with your didactic work. And then you also complete, at minimum, of about 1,000 hours of clinical experience in addition to those didactic courses. Just a little side note, this is actually more hands-on training than most other entry-level healthcare programs, meaning CNAs and nursing included. Our education and what gets you ready to take your certification exam is based heavily on competencies. Competencies mean that you can demonstrate competent in a certain exam. So we need this much time in the clinical field to demonstrate proficiency in a minimum of 50 imaging procedures. This is what you will need to prove competent in order to sit for your board exam. Next misconception is that all we do is image bones. Unless you work strictly in an orthopedic office, you will be exposed to imaging next to every part of the human body. We do a lot of functional exams under fluoroscopy, which we look at digestive tracts and urinary tracts. And we'll get a little more into this later. We'll discuss some of the common areas that we work in. But just to note, unless you're working in an orthopedic clinic, we do x-ray more than just bones. Another common misconception in the general public is that we are exposed to radiation, so this makes it a dangerous career. And while yes, of course, we do work with radiation, we have strict safety protocols, we wear protective equipment, and this new modern technology that we're utilizing really does minimize our exposure. So yes, it is a safe career. Our radiation exposure is monitored by physicists throughout your career, not only as a student, but as a technologist until you are no longer practicing. And you'll be formally educated as to how you can properly protect yourself in the field. Next, people think that we really don't play a role in patient care. And while yes, a good amount of our procedures are fairly quick, we do interact directly with all of our patients. We explain procedures, address their concerns, and throughout, we're ensuring their comfort during these imaging procedures. Whether it's 5 minutes or an hour, we are involved with their care. A critical aspect of our job is positioning patients correctly, so that obviously requires direct hands-on care. So yes, you are touching patients. And then lastly, a lot of people think that radiography does not have opportunities for career advancement. Not only can you get a full-time job as an entry-level technologist as soon as you pass your board exam, you can then choose to further specialize and then educate yourself in other areas, such as interventional radiography, CT or CAT scan, MRI. And then, like I had said before, you may want to go into education. There's research and management roles. There's technical jobs. We'll get into this a little bit later. But again, just a very common misconception, but it couldn't be further from the truth. So what is radiography? Radiography is the art and science of using radiation to provide images of bones, tissues, organs, and vessels, all that comprise the human body. Radiologists take our images or our radiographs. They've had special training in interpreting images, and they use these images to help diagnose and treat patients. They use this in addition to other medical treatments and clinical histories, but as you can imagine, we are basically the eyes of the radiologist. The radiologist doesn't meet every patient that comes in for an x-ray. They look at the images and they use that in part of diagnosis. So again, what we do needs to be very precise and accurate. And the radiologists put a lot of trust in our hands to make sure that we are getting the imaging that they need to make a treatment plan or diagnosis. So next, let's take a quick look at a very basic breakdown of how an X-ray image is created. So we're going to break down basic X-ray image formation. Obviously, there is a lot of physics that go behind this that we will educate you formally in class, but to give you a general idea, X-rays are a type of electromagnetic radiation. They are on the electromagnetic spectrum. They are similar to visible light, but with a much higher energy. X-rays can penetrate human tissue and bone, which is how we view internal structures in the body on a radiograph. So basically, an X-ray image is formed by different attenuations of the X-ray beam within the patient's body. That just means that when X-rays pass through the body, they interact with tissues. More dense tissues, such as bone, absorb more X-rays and appear white on the image. This is why X-ray is largely equated with and utilized for bone imaging, not to say that we can't see other things with our imaging. Less dense material, like muscle and fat, absorb fewer X-rays, making it harder to distinguish on X-rays, so they appear darker or more black. We would need the use of a contrast agent to be able to visualize some of these, which we'll talk about later. So again, that differential absorption of tissue or bone creates the contrast needed that we can visualize these internal structures. So to break it down even more basic, X-rays that exit the body are captured on our image detector, and this results in an image or a radiograph. And again, it displays those various densities of tissues, allowing for diagnosis of fractures, tumors, and other pathologies. So again, we can see here on the right, we have a radiation generating source. We direct it towards our patient. It interacts with tissue particles, and then that absorbed radiation is processed on the image receptor, and that is how we produce a radiograph. Before we can talk about the new technology that we have here and that we are exposed to, we'll just talk briefly about the history of radiography and some of the advancements that have been made. So to start at the very beginning, the discovery of X-rays dates back to November 8th, 1895, so well over 100 years ago, when Wilhelm Röntgen, a German physicist, accidentally observed an unknown form of radiation that could pass through objects and produce image of bones. So again, this was found out not on purpose. Turns out to be one of the biggest discoveries in science. And he actually went on to win the 1901 Nobel Prize winner for the discovery of X-rays. His first recorded X-ray image was his wife's hand that we can see in the top left corner here. And it is her hand as well as her wedding ring. This photograph of his wife's hand was the first ever photograph of the human body by using X-rays. Again, this was a groundbreaking discovery. It actually earned him one of the first Nobel Prizes in physics in 1901. Starting back in the 1900s, there were first a few medical applications for X-rays, but very little awareness of radiation protection. So we'll see how that kind of progressed through the years. So again, Wilhelm Röntgen discovered X-rays in 1895. The early 1900s, we started with first medical applications, but again, there was a lack of radiation protection at this point. That's that image on the left there. In the 20s and 30s, led to image improvement and radiation safety. So they actually had awareness of radiation hazards and led to the use of protective shielding and started making those exposure limits. So we had a better idea as to what a patient or a technologist could be exposed to. In the 1950s to the 70s, there was a lot of technological growth. We improved image contrast and again reduced exposure time and doses. This is when a time of screen film radiography was being employed. Computer tomography, or CT, was discovered in 1972. So again, a lot of technological advances in the 1950s through the 70s. By the 1980s to the 1990s, there was a digital evolution of radiography. We were doing computed radiography, so that was called CR. It replaced the traditional film, which we can see in the bottom right-hand corner here. We used to do film screen, where you would develop film just like you did or somebody did back in the day with regular photographs. Into the current future, from the 2000s forward, we have turned into digital radiography, or DR, which most of the state, I will say, has upgraded to DR technology by this point. And DR is really when we use what we call flat panel detectors. And basically every image is collected on one panel and stored through a picture archiving and communication system, PACS. So we really digitize into the modern day. We're able to take images, store images, and retrieve them and share them all electronically. So again, we got rid of film and now everything is digitized, and it's making it much easier to kind of pull together patients' imaging across different platforms. And up till now, modern X-ray advancements, AI and machine learning enhance image analysis. So we've had a lot of upgrades in that. Every few weeks, I feel like I get a new continuing education article on the new advancements here with this technology. We have lower dose techniques than we ever have before. And the newer systems actually improve our diagnostic capabilities with less radiation. So just so you know, we've made a lot of advancements. We use much less dose than when X-rays were first discovered or first started to be employed in medical applications. We also have portable and wireless X-ray systems, making it easier to, access everybody in emergency situations or remote settings. So we have made quite a few advancements and still continuing to do so today. So what do we do on a typical day as an X-ray technologist? As you can see down at the bottom, I kind of listed some of our terms that people like to call us. We are a radiologic technologist. We could be called a radiographer. An X-ray tech is what most people call us, or an RT. So very basic, what we do on a daily basis is we position patients, we perform X-ray examinations while ensuring patients are safe and that we maintain proper image quality. So again, positioning patients, we are hands-on, we are positioning these patients very specifically. We are not just telling patients what to do, we are manipulating their body in certain ways to get certain positions. We operate X-ray equipment and adjust technical factors for various procedures. That means we're setting our radiation techniques. We set different types of parameters on our equipment to help get the imaging that we need. So again, a lot of education into how to set proper techniques is required. Our main role that we need to do is to minimize radiation exposures for not only the patient and us, but other healthcare workers and the general public. So we learn about protective measures and then dose optimization, how we can lower dose and still get good image quality. And then lastly, every day you are collaborating with other healthcare professionals, radiologists, nurses, doctors that come in and want to see their exams. So we are very heavily involved. It is a team environment. So it's not only just you working in an X-ray room alone. We do have a lot of collaboration with other medical professionals as well. So radiation safety, this is talking about protecting ourselves, but also the patients, and then again, also other healthcare workers who are in the same field that we are if we are administering radiation. The key principle that we follow is ALARA, which you can see in the lower left-hand corner. That stands for as low as reasonably achievable. And this is us talking about the dose that we are giving our patients. We want to make sure that we're giving the lowest dose possible while still maintaining image quality. Additional measures to protect ourselves or people who are within the radiation area would be wearing personal protective equipment, such as a lead vest and skirt that we see here. There's also thyroid and eye protection, not seen in this image, but we'll speak about that later. And then we also wear a personal dosimeter. That's what this is up here on the right. And it measures the whole body dose of what you receive while you are working in areas with radiation. This is monitored by a physicist. Just a little background information, I've been a tech for almost 13 years, and my total lifetime dose, not only from being a student, but being a working technologist, is about 0.5 rem, so half a rem. That's my total life dose. And as any person, whether you're working as a technologist or just a patient, the permissible dose is 5 rem a year. And my total life dose is only about half a rem. So again, we would teach you about all these standards and you would learn more about this, but just to put it in layman's term, I have had very, very little radiation and I've worked with live radiation often in my job. So now I want to take you through a day in the life of an X-ray technologist within the different clinical areas that we do rotate through. I would say from working in the field, a good X-ray technologist really needs to express dedication to learning their craft, meaning you really need to understand the equipment and technology that you're working with. I would say almost every day something comes in where it's a new imaging technique or I learn a new tip or trick from a fellow coworker. Again, you're never done learning in this field, and it's important that you keep yourself educated and want that and demonstrate dedication to that while you're an X-ray technologist. Also, attention to detail is really important. You really need to constantly assess your images and make sure you're meeting image standard quality. So again, attention to detail is very important. You need to have good interpersonal skills because we work with, again, a variety of healthcare workers every day. And then patients, they rely on your expertise to get medical treatment. So we again want to be able to empathize and show compassion with these patients. Sometimes we see them on their worst day, and we need to be not only efficient at our job, but also maintain that personal relationship with them and make them feel comfortable in order to get the best images that we need. And then finally, I tell my students this every day, if you're going to be a good X-ray tech, you need to have good problem-solving skills. You need to be able to adapt to different clinical scenarios, think quickly on your feet, and be able to adjust at a moment's notice. But we'll talk about that as we get into each of these areas here. First, I just want to show you some of the typical X-ray equipment that we are expected to use and know. Down here in this left image, this is an example of a typical X-ray room. Here we can see the technologist is positioning our X-ray tube over a patient on the table. We can take images on the table here, or this is called a wall bucky, where we are able to do standing images as well. This top image up here is a piece of portable equipment. We will talk about this in a little bit because that is a main rotation during our clinical education. We are constantly working with computers. All of our images are digitized on a picture archiving system, so we need to be familiar with a lot of different computer systems. And then again, we can take x-rays at just about anywhere, so there's a lot of different types of equipment that we do have to familiarize ourselves with. There's actually jobs where people travel with equipment that can be transported in a van, and they use a portable unit to go to nursing homes or rehab centers and provide exams that way. So a lot of different types of equipment that you will be exposed to and learn about. The first area that we rotate through and we get a lot of clinical experience in is called fluoroscopy. And fluoroscopy is a medical imaging procedure that uses low intensity beams or pulses, so they're brief bursts of X-ray that show internal organs and tissues in real time on a computer screen. So standard X-rays are kind of like photographs, whereas fluoroscopy is like a video. So healthcare providers, meaning radiologists or physicians, are the ones who actually manipulate the machine for the live x-rays. So they use the fluoroscopy and they use it for diagnostic purposes, so they can take a look at the functionality of a system. It's usually the GI tract that we image or the urinary system. But we can also use fluoroscopy in treatment procedures, meaning we are going to place a stent or a catheter under fluoroscopy guidance. Radiologists, again, operate the equipment while we assist with the patient or anything that the doctor may need. The most common areas that we see are the cardiovascular system, the digestive system, and urinary system. And notice that these two images, the radiologists here are wearing lead. Again, we are always wearing lead when we are in the room with live radiation or fluoroscopy, as well as our standard x-rays. Here are some of the standardized images that you may see any given day while you are working in the fluoroscopy department. So if we look at this image here on the left, we are looking at the image of a esophagus and stomach. What you can see in this film is a contrast agent called barium. The barium is showing up white in this image. And this is a contrast agent where it is used to highlight soft tissue structures that are hard to visualize without. So it's hard to visualize the stomach without the use of a contrast agent. So this patient drank barium, and now we are able to look at the shape of their stomach, if there was any abnormalities. But this here, the white part, is barium. So barium shows up white on our radiographs. There are many types of contrast agents. Barium is the number one that we see and utilize, but there are different ones that you will be educated in, and their use would be depending on different clinical indications. So again, we use contrast to highlight things that we normally see. This image here is of a urinary tract. We're looking at someone's kidneys, ureters, and their bladder here. This image on the bottom is from a barium enema procedure. This patient is lying on their side, and we are looking at their intestines while they're lying on their side. Again, this white here, seen in the large intestine, is the barium. And then this image on the far right, this last one, is actually an instance of aspiration. So somebody aspirated barium. Instead of it going down their esophagus into their stomach, it was swallowed into their airway. So again, this is us looking at somebody who has a problem with swallowing. Mostly what we tend to see on a daily basis is, again, imaging of the GI tract or the urinary system. Next, we have portable radiography. So that term is referring to us performing X-ray imaging using that mobile X-ray unit, and this would be at a patient's bedside or outside the traditional radiology department. So again, like I said, we can travel to other patients outside of our department, whether it's still within the hospital or outside the hospital as well. This service is crucial for patients who are critically ill, immobile, they're in some type of isolation precaution so they cannot come into the general public area. And this way they can get care that they need without being transported down to the radiology department. Portable x-ray exams that are often seen, we usually go to the intensive care unit or the ICU. We are often involved in emergency rooms, so not in our standard room. We'll actually travel to patients' emergency rooms. We go to surgical suites, and then we go to in-house patients, so in the hospital, who are again too sick or too injured to travel down to the imaging department. Almost every exam can be taken portably. Portable images may sometimes have lower image quality due to some of the limitations of the equipment and just generally patients' positioning. Unfortunately, these are very sick and ill patients that usually can't travel, so it may not be as great of a standard of image quality, but we are able to get some type of image for patients who cannot travel to us. And we'll look at some of those images coming up. Here are some of the examples of the portable equipment that we use in the hospital and that can also travel outside of the hospital. Again, this equipment here is a really portable piece of equipment that actually is very compact and can travel inside the use of a van. This is one of the newer innovations that we are actually able to travel with true portable equipment outside of the hospital. These two pieces of equipment here are just our standard portable equipment. We can go into patient rooms, we can drive right up to their bedside and perform almost every exam while maintaining image quality. Again, you could spend your day on a portable rotation just traveling to different places in the hospital, taking x-rays on patients who need that quick and informative x-ray but are unable to travel down to the department. Most common studies include chest x-rays. That is the most common radiograph that we will take as a general statement in our career, but mostly when we travel up to patients' room, we are taking chest x-rays. We are usually assessing for conditions like pneumonia, heart failure, pneumothorax. We look for a lot of placements of medical devices. So if somebody is intubated, like these two images here, these patients are in the intensive care unit and they are intubated to a breathing machine. We actually look for the placement of those tubes to make sure they are placed correctly and the patient's getting the correct breathing treatment that they need. We do a lot of abdominal x-rays for detecting obstructions and more medical device placement. We take skeletal x-rays, so people who've just had new fractures, we're able to travel to their bed and take them here in the bed. And then again, we actually do a lot of neonatal imaging up in the patient's room. It would be a crib or a toddler bed. We can do them right in their room without having to make them come down to the imaging department. Like I said, we can travel almost anywhere, but we are usually found in the intensive care units, emergency room, and then the operating room. So we'll talk about the operating room and the emergency room next. X-ray guidance in the operating room, or the OR, is used to assist surgeons and doctors in real time. So during their procedures, they require precise imaging for placement or alignment of bones or implant verification. We use fluoroscopy or even standard images just to help guide instruments, implants, and other surgical tools. So now the surgeon doesn't need to wait till after the surgery to see how his placement was. We'll be there right during the surgery giving him real-time information. That way they can limit the need to have repeated incisions or going back in to have extra surgeries just because something wasn't done properly. Again, we are in there in real time, so we are using live x-rays, so we would be wearing lead as well. We can see that in this image here. But we are manipulating equipment around the patient while they are operating. With that, we are using this piece of equipment called a C-arm. Obviously, here we can see it looks like a C, and it can rotate over the patient in a few different manners. We can get next to any image that we need with this piece of equipment. We'll talk about some of the challenges here working in the operating room in just a second. So like I said, we are here in the operating room taking either live x-rays, so like a video, while they inject contrast into a vessel, or we're taking static images where we're looking at the placement of screws or whatever it is they happen to be placing in a patient. So some of the common x-ray guided procedures that we see in the OR are orthopedic surgeries. We do almost every orthopedic surgery that involves the fixation of a bone. So if you have a fracture, they may fixate it with plates and screws. So they align the bones and put hardware in there to help heal. We're there for spinal surgeries. People have screws put in, discs taken out, things like that. We're involved in those cases. We are involved in almost every joint replacement case. We ensure that they properly position prosthetic hips, knees, shoulders, just to name a few. And then we are also involved in vascular or endovascular cases. So angiography, which is basically we're looking at blood vessels. So we do a lot of contrast into blood vessels when people need stents put in to open up arteries, things like that. And then we're also heavily involved in urological procedures. So again, that's your urinary system. Whenever somebody gets a kidney stone, they use fluoroscopy to visualize the kidneys and the ureters and make sure that they are able to drain. We watch them place stents under fluoroscopy to make sure that they can open up the urinary system so that they can pass urine and not cause additional problems. And then again, notice we're always in lead when we're here with live x-rays. On this slide here is just a newer piece of equipment that I always like to update with my students. This is called a O-arm. Obviously it makes sense. It is in the shape of an O. This machine actually opens up here, and this will open while they bring this machine over the patient, and then it becomes a O, and it can perform what we call spins. So we will actually take 3D imaging. So the O-arm forms a ring around your body and then rotates to take 3D images. It is a really cool new advance that we have here. It's used for intricate spinal surgeries. There's actually a navigational component, kind of like a GPS, that allows the surgeon to track instruments in relation to the patient's anatomy. So it's very precise with positioning and placing screws and plates and things like that. So this again would take additional specialized training that you would get as a technologist, not as a student, but just so you can see some of the newer technologies that we are exposed to here in our clinical rotations. So one of our key responsibilities while working in the operating room is maintaining a sterile field. Basically, that's saying we need to know what is sterile and what is not sterile and how we navigate around it. Anything that is sterile, we want to avoid direct contact with, because if it is touched by something that is non-sterile, it now can no longer be used in that case. So anything that is sterile is something that has been highly sanitized and is able to be placed in the patient or used on the patient. Our equipment is generally not sterile, so we use things like drapes to kind of cover over when we're over a sterile area, but the most important aspect of our job is being able to communicate with the staff so that we are maintaining that sterile field and able to work around it. All of which we would give you the proper education and training to go along with it. Again, this is why we have so many clinical hours that we put in. We do work with you to get these cases. There are a few proficiencies or competencies that we do have you get within the operating room, because it is something that is required. We are required to know how to work in the operating room. Every technologist or student does complete a rotation, if not more rotations in the OR, and everybody does get their competencies. And while it may seem like a scary environment, it is actually very controlled, and these procedures, for the most part, are very planned out and methodical. So you are already aware of what that procedure is and what is expected of you. So we'll talk about some of those procedures and the images in just a second. I just wanted to point out some of the tools and devices you may see being used in the OR. These are devices used in orthopedic cases. Again, they look just like regular power tools, and they are. They are just for used with bone, and they just have medical grade equipment that is attached with it. So yes, basically power tools. We see these operate a lot. And then again, there's a lot of planning and preparation for these procedures. So all of these tools are measured out ahead of time. The sizing of an implant and the screw size we would do under our live x-ray to make sure that it is the correct size. And honestly, it is a very cool opportunity to observe cases up in the OR. It's fascinating, and it actually helps you think critically as to how you can get some of these images without being able to manipulate the patient at all. So now you are manipulating equipment instead of having the patient position, moving their body or their anatomy. We are actually using equipment to rotate their anatomy. So again, a very fascinating and educational rotation that every student goes through, as well as maintaining a few competencies in this area as well. Here are just a few images that you may obtain while you're working in the OR. These two images up top here are images of a left hip prosthesis or a hip replacement. This image here is taken with the C-arm when we are in the case. And then this image is post that we take in recovery with our portable equipment. They are looking at measurement to make sure that they are measured correctly and aligned across both hip joints here. So again, they do a lot of measurements. They want to make sure that everything is properly placed because we don't want the patient to have any issues from improper placement. We also, again, here's another urology case. We are highlighting the kidney and ureter with contrast. Again, that's this white here. This image here is from an endovascular case. There was contrast injected, and we are looking at vessels, so arteries and veins, just look for blockages. And then finally, the most common orthopedic case we do is spine cases. This is a severe case of scoliosis, so a lateral curve in the spine. And now this patient had screws and rods placed to help straighten the spine, which we can see has helped a lot here. Okay, we're finally on to trauma center and emergency room imaging. So a trauma center is a fast-paced, sometimes physically, emotionally demanding environment where us as X-ray techs, we play a critical role in patient care. And our primary responsibility is to provide rapid and accurate imaging to help assist those physicians in real time so they can diagnose and treat life-threatening injuries. While I say all of that, most of the time we see patients in the emergency room images for broken bones or, heart attacks, strokes, things like that, where not everything is very chaotic. So these next few slides are some trauma scenarios that I want to warn you that the images are a bit graphic. So if you do need to look away, I would look away now. We'll look at a few of those images and then we'll move on and talk on the next slide. So these are obviously some truly life-saving images here. Again, this may not even be seen on any given day in the emergency room, but this is what you may run into at any point in your clinical rotation. So not representative of every day in the ER, but something you may see while you go through. We generally work with just critically ill or sick patients or, hurt patients with fractures or cuts. But again, some of these images are going to show up in your clinical rotation, and you do have to be aware that you need to work around them. We see a lot of people with bones, unfortunately, that are no longer within their skin, or really bad fractures that are still within their skin, but just a bad fracture. So we need to be able to operate around that. So we'll talk more on this next slide here. So not everything is bloody and chaotic all the time in the emergency room. Here we have an image on the left of a trauma room. So it is pre-trauma. It's prepared for when a patient comes in at any given moment, so they are ready to help take care of that patient. And traumas can range from anything from bad car accidents to bad falls. It could be gunshot wounds or even just critical care patients like strokes and heart attacks. And while yes, some traumas may be serious and intense and you do need to work quickly and efficiently and with a lot of other people working in the same room, again, a lot of them are just critically ill patients who need care fast, so don't let that scare you. Again, you'll be in that area, you'll know how to operate accordingly. And just to give you a little background information, on average, the emergency room or trauma is the most requested rotation by my X-ray students. They really like the ER. It gives you a chance to really practice your critical thinking skills. It really is satisfying when you can figure out how to get images in a non-traditional way while not, causing more damage to your patients. It really is satisfying to know that you know how to care for that patient in a non-traditional way. And then again, when you're in the emergency room, our typical day and responsibility, we're usually responding to a pager. It gives us trauma alerts that we know that we need to quickly mobilize to the ER or the trauma bay and perform whatever stat x-rays that they'll tell us there in the room. So on top of getting to critically think, you need to how to figure out how to, obtain your images, while other people are working in the same area. So you're working with a part of a larger team. You are really involved in teamwork when it comes to the emergency room and trauma. And, despite these challenges, it really can be incredibly rewarding and offer dynamic work environment. It is always different. We say you never know what you're walking into when you're working a shift in the emergency room. So again, a very good rotation and something that you'll definitely have to prove competent in. And again, one of those really popular rotations that students really like. Here are just some standard trauma radiographs. For the most part, they include fractures. That's generally our trauma is going to be fractures of bones. We can expect to x-ray any patient that comes in with a question of a fracture or dislocation. That's probably the most common. But also we see a lot of sick patients in the ER. That's another exam that we're always doing is a chest x-ray. So looking over here, we have a patient with a broken radius. So this is the bones in your forearm. And we usually take initial radiographs. So right when that patient comes in the ER and they're crying and we don't know what's wrong, we're the first people to see what's wrong in that. We'll take those images, the patient will get a room, an orthopedic doctor might come and then set this bone. So they're going to realign it and then place that patient in a cast, and then they'll come back to us for imaging and we'll see if they have aligned the bone satisfactory. This is a bad femur fracture, so this is the bone that goes from your hip down to your knee. Again, these are true traumas. This is a very serious break, so we would be there in the trauma room looking at that. And then this is a patient who had previously had a broken ankle and then now has broken it in 2 other places. So again, we do see some true traumatic injuries here, but it is nice to know that you are helping in that patient's care from start to finish. You may see them when they're crying and in a ton of pain right in the very beginning in their first injury, and then you see them again later when they've been able to set the bone and relieve some of that pain, and those patients are really thankful for what you do, and it's just nice to be a part of that. And again, I wouldn't be able to not talk about the emergency room to mention that, again, we do see patients from unfortunately bad accidents, and this is a case of gunshot wounds. This is someone who was shot in the skull. We have the chest and then a broken humerus or upper arm with a bullet here. So again, we do need to know how to work around these, not that this is on every given day, but you will be trained in how to perform these exams in these cases. Okay, next, here is our orthopedic center. So an X-ray tech in an orthopedic center plays a vital role in imaging when we're looking at how to help treat musculoskeletal conditions. So unlike the fast-paced nature of the emergency room or trauma center, ortho clinics offer a more structured environment. It's really more focused on outpatient care, but this is where you actually are required more precision in your images than any other clinical site. Orthopedic centers require really precise imaging, and this is where you really get to hone in on your x-ray skills. So a typical day would probably be performing routine imaging of bones or joints for fractures, arthritis, deformities, and then a lot of post-surgical follow-up patients. They do a lot of different things like specialized views. They do weight-bearing studies where we have this patient weight-bearing and we're going to evaluate their entire spine and joints to see what that functionality has. And then, working in an orthopedic center, we are working with a lot of patients in pain. They may have mobility issues or those post-surgical patients who are still having trouble rehabbing. So it does require you to get really precise imaging with patients who are not able to mobilize as well as we'd like them to. So we know orthopedics is the branch of medicine that's concerned with the musculoskeletal system and then all the associated structures like ligaments and muscles. So obviously when we're here, we're imaging bones. Orthopedic clinics generally have a very steady flow of patients, so they are very booked, and you need to make sure that you are being quick and efficient while also following strict guidelines that usually each surgeon has a very strict guideline based on a protocol. So a foot protocol, instead of the standard 3 images, they may take 6. For the knees, instead of taking the standard 2, they may take 4. So again, you really get to hone in your skills in these orthopedic centers. We do a lot of imaging so they can do measurements like we see here in the foot. They're measuring the arch of the foot. These are images post-injury, so they have a fractured radius here. So they'll take these images and then bring them up to the operating room and have that fixed. This is a post orthopedic fixation case, meaning they fixed a fracture in the tibia or the lower leg, and now the patient's in a cast and they've come back for post imaging just so they can see how the healing is going along. And then these images here, we do a lot of comparison x-rays. So this is two standing knee x-rays. So they're comparing the knees to see which one, in this case, is more arthritic. These are both arthritic knees, so they're looking possibly to look for joint replacements. And then a typical workflow for orthopedics includes imaging from the initial injury through the surgery and then post-op. So again, this is a picture of an elbow. So this is the humerus bone, and then this is the radius and ulna, so part of the forearm. This patient has broken their humerus pretty bad. They went to surgery and had it fixated or fixed with plates and screws so that the joint can be maintained. And then we see them again from start to finish, pre-injury, while they're in the case, and then post-op to help follow that injury along. This here, I just wanted to show you a typical elbow image as to, what a surgeon really can do with our guidance with a C-arm in the case, as well as our pre and post-op imaging. And then finally, our last clinical rotation that we do go through is working in a pediatric x-ray center. Obviously, when working with pediatrics, we know that this is going to require specialized skills and training. We really need to know how to communicate with children. We need to make sure that we can get the same images and the image quality that is required, but obviously maintaining children's comfort and safety. So pediatric radiography has a lot of challenges, but again, as you can imagine, it can be incredibly rewarding. Usually our daily responsibilities when we talk about pediatric x-rays, we are working with all the way from neonatal up to children of 18 years old, so from newborn to teenagers, for conditions like fractures, infections, maybe a congenital disorder, just to name a few. We can see in this image here, we still do live fluoroscopy with children, so we would be the technologist helping to position that patient, as well as our standard general x-rays where we may be tasked with helping to hold the patient in a position while maintaining comfort for the infant or the child, just to help reassure them that they are okay and they're in good hands while you are taking their radiographs. So like I said, communication with pediatrics is key when getting our radiographs, explaining procedures in a child-friendly manner, and then also reassuring not only the children, but the anxious parents that are with them. That's a large part of our job. So a lot of this, we have you observe an entire rotation, and then you step in and you start to help the techs in this. There's a lot of immobilization techniques and positioning techniques that we use. We sometimes need to use restraints to help get patients in the position that we need. And then, of course, we always want to practice radiation safety, but even more so when we're talking about working with pediatrics, we really want to make sure that we are on point with our centering and the technical doses that we are applying, that we are using the lowest that we can while working with pediatrics. Here's just a few examples of some of the positioning aids or techniques that we might use to help position a patient. So we use gentle restraints. Again, we are not holding down patients against their will, but we are kind of helping them get that position. So we may utilize tape to help keep their arm in a position. If they're unable to understand what's happening, we use some, either some weights, we use tape. Here we can see some lead shielding as well. These two images on the bottom here are of what is called a pigostat. It's actually a great tool to use for toddlers for chest x-rays. It helps put them in the position that we need, so we minimize repeat exposures by the patient not being able to maintain the position that we need. So this helps set them up for a chest x-ray while getting their arms out of the way. Again, it may look a little scary, but it's actually a great tool. These are just some a paddle to help keep a hand flat for x-raying a hand. These are some other weights to put on the side of the body to keep the patient from rolling off the table, because obviously we want to make sure the patient is safe on the table while we take the image. So again, we have a lot of different techniques that we can help to use to get good images on pediatrics, all of which we will learn here with didactic education as well as hands-on training. So a typical workday in pediatrics, we see a lot of children come through the emergency room for swallowing foreign bodies, or in other words, anything that they shouldn't have swallowed. So in this case, we see a child has swallowed a coin. So we are looking at a front view of the chest and then a side view of the chest. We want to see where that coin is in the esophagus, and that it is indeed in the esophagus, or the structure that goes down to your stomach, and not the trachea or the windpipe. So this is not blocking the patient's respiration, so they're able to breathe. And then, of course, we know that kids run around and jump off things they shouldn't. So we see a lot of breaks in children, so fractures. So we do a lot of orthopedic x-rays. In this example, this child fell out of a tree and broke their femur. So a lot of challenges when working with children. They may be fearful, they may cry or move during your exam, but we kind of work with you again with those positioning aids, and then communication really helps with positioning patients for the exams when you're working with pediatrics. And then again, we're always working with parents or guardians, so we also need to be able to address their concerns while keeping the child calm and then working around them efficiently and quickly. We need to utilize a lot of creativity to really, make a stressful experience turn into, a positive one, and make sure that the child is comfortable as well as the parents. Again, this is all training that we would give you didactic education as well as hands-on training in the clinical field. So finally, we'll talk about radiography careers. So we touched upon this a little bit, but now I'm going to break it down a little bit further as to where you can go once you get your board certification, take your exam, and now you're a registered radiologic technologist. So again, once you're done with your formal education for becoming a radiologic technologist, you will sit for your board exam, and if you pass your board exam, you would then become a registered radiologic technologist. X-ray techs that have their certification, they now have the opportunity to expand their expertise, and they can go into specialized areas and try and get additional certifications. So you may want to advance into computed tomography or CT, also known as CAT scan. There's MRI, nuclear medicine, cardiovascular and interventional radiography, so working with vessels and angiography. You can also go into mammography. Again, a lot of other specialized areas where you may not need to complete another full year. You may only need another 6 months of didactic or education followed by clinical experience. There's other paths such as radiation therapy or medical dosimetry. Those are or play a crucial role in cancer treatment planning. Those require a little bit more education than just going into another modality like CT or MRI. And then additionally, higher experienced technologist or someone who wants to really pursue an advanced role, you could go into looking into being an RA or a radiologist assistant, where you'd work closely with radiologists in patient assessment and actual image interpretation. They may take fluoroscopy images for those patients. So a lot more advanced. You would need a lot more schooling with this, but still another opportunity that you could have. And then again, travel technologist is one of the newer opportunities that we've seen grown since COVID. You do need to maintain a certification for at least a year for most companies that will employ you as a travel technologist, meaning you need to get some experience before you can go and travel to other sites. But it is another great opportunity where you're able to travel, and travel technologists do make more than traditional technologists, so it is a good opportunity for you as well. Beyond the clinical environment, certified X-ray techs have a lot of other options or opportunities as well. You could transition into education. So you could help train future technologists and contribute to academic programs within a hospital or at a structured education. There's also health service management, meaning you could go on to take on leadership roles, either management or lead tech roles. You can oversee image departments. You may need additional education after that, but again, another great option. We have PACS administration, which is again our image acquisition system, where you could be an administrator. They manage digital systems, they manage workflow and data security, so more of that kind of IT background. You could also go into quality or research. So quality, we have a quality assurance program where we look at optimizing image quality, radiation safety, and compliance. Those interested in research can also contribute to advancement in imaging technologies. You could be a part of a research role. And then finally, there's also the technical roles. So that includes equipment sales or application support. So anytime a new piece of equipment is installed, there is someone who would be your point person or contact person if you have any issues with the equipment or just questions about equipment. Then there's also product development. If you worked with a company with GE, they're always looking for input from X-ray technologists as to how better the equipment or make it more user-friendly for us. So there's, again, a lot of other career pathways that are not in the clinical environment as well. Okay, and then finally, probably the most important question you have, because none of us want to work for free, but how much will I make? So I found these statistics. It's per the Bureau of Labor Statistics from 2024. Typically, new graduates start on the lower end of the salary range, so somewhere between 55 and 65,000 a year, but the average is 73,000. And then again, that's your entry level, and that will change with a variety of factors. So experienced techs can go up to 70 to 90,000. Advanced roles can go up to 6 figures. People who are in management roles or other things like that. But all of this is based on a few different things. So first, entry level versus experience. Obviously, the more experienced tech will have a larger salary. This talks about our clinical setting and work environment. So, meaning hospitals generally offer the most pay and the most opportunities. When we talk about working in a hospital, especially with X-ray, because X-ray is staffed 24/7 in a hospital setting, they have what is called differentials. So a differential is additional hourly pay. So if you were to work first shift, there is no differential. For second shift, you may get an additional $2 an hour on top of your base pay. Third shift is more. Weekends are also additional, as well as holidays. There's also call that you can take in a hospital setting that you can add, where you get paid an hourly wage just to be on call. So if they need you emergently, they'd call you in. But even if you don't get called in, you're still paid for the time that you are on call. When we talk about other work environments, outpatient clinics, they usually have a lower base pay, but they can offer consistent hours. And sometimes they have better benefits too. So, not to say that working at an outpatient clinic is not a good idea. They just generally don't make as much as a hospital tech would. Also with that, specialization, that comes into play, and it's a big role in what your base pay will be. So if you are a technologist who is just X-ray, you will probably make less than somebody who has both X-ray and a CT certification. Obviously, the more specialization that you have increases your base pay or your salary. What also contributes to your pay is your educational background. So again, do you have an associate's degree? Do you have a bachelor's degree, a master's? That can help boost your pay as well. And then again, when we're talking about certifications, do you have a certification as just an X-ray tech? Do you have a RA license? Did you go for medical dosimetry? Things like that, that will influence your salary. Geographic location and the cost of living, that plays a big role. I will say that Massachusetts is one of the has one of the higher costs of living, but also tends to have higher salaries. So Massachusetts, New York, California, highly populated places, those offer generally higher salaries, but it's usually in lieu of their higher cost of living. So rural areas may offer lesser pay, but they may have, hiring incentives or better benefits. And then finally, like I mentioned before, travel techs can earn significantly more. So almost sometimes 2,000 to 4,000 a week, depending on the assignment and the location. Of course, like I said, you need to at least be an experienced technologist for at least 1 year. I want to say they prefer at least 2 years of experience before becoming a travel technologist. But you can also get added perks if you're a travel tech, like housing stipends, travel reimbursements. So it is a very lucrative aspect that you could get into. But again, you should get a good uh, year or two experience before going into a travel technologist role. And then, again, final thought, I always like to say, think about working in a hospital. There's so many opportunities there. You get to job shadow in different areas. There's, again, benefits. Overtime is really large right now. We are in desperate need of imaging technologists. So overtime can really help boost that base pay. Um, you know, Unfortunately, things like mammography and nuclear medicine, they are a first shift or day shift modality, meaning that they don't have those added benefits of working second shift or nights or picking up call. So, you know, while of course it would be nice to work 9 to 5 just during the week, it is also nice to be able to work around, other people's working schedules. If you have children, you're able to kind of work around that. So there's a lot of choices and you have more availability to work in X-ray than maybe some of the other imaging modalities. Thank you for taking the time to listen and learn about the rewarding career as a radiologic technologist. Again, I just want to reiterate this profession really gives you an opportunity to make a difference. You get to learn advancing technologies, practice patient care, and then, have a lot of different evolving environments. You can really push yourself in your professional growth, your career growth, and there's just a lot of opportunities that come with being a radiologic technologist. I wish you all the best in your educational journey and future careers, and then I hope I see you in the field in the future.